people displaced by crisis now than there have been at any time since the cataclysm of the Second World War. Women's health and rights are under siege when natural disasters topple hospitals, when conflicts undermine rule of law and heighten vulnerabilities to rape, when an epidemic makes it unsafe for expectant mothers to seek services of a midwife or go to a clinic, like happened in the Ebola crisis. Family planning, reproductive health services, safe childbirth are rarely met when women and adolescents become untethered from the lifeline of health systems. This puts them at a heightened risk of sexually transmitted infections, and that includes HIV, at a higher risk for unintended pregnancy, illness, and even death. Without the protection of family, friends, and community, women and girls are also at higher risk of falling victim to sexual violence. Whether women live or die in a crisis can depend on whether they can get sexual and reproductive health services, deliver safely, access contraception, be safe. Secondly, we need to step up investments in prevention and preparedness to mitigate the impact of future crises. We need to invest in resilience of governments, of institutions, of communities, and of individuals. Actions to promote equitable development that benefits women, men, boys, and girls alike, can build in society resilience and cushion the shock when disasters strike or conflicts break out. The other way around also, humanitarian response, if it is done in a way that promotes gender equality and meets everyone's needs, can lay the foundation for rapid recovery and post-conflict and resilient development after that.
Especially vulnerable within this category of people are the 26 million women and adolescent girls in their childbearing years. It is very important that UNFPA in this year's State of the World report focuses on and sets a transformative agenda for women and girls living in and growing up in a crisis-prone world. The Netherlands continues to be a strong advocate for safe abortions for all women who have decided they want to terminate their pregnancy. All women should have access to not only contraceptives, but also to emergency contraception and to safe abortion services in all situations, including humanitarian emergencies.
Today, humanitarian actors are doing a better job of taking essential actions and providing basic reproductive health services. This is known as the minimum initial service package for reproductive health. The objectives are to prevent maternal and infant mortality. The second objective is to reduce the transmission of sexually transmitted infections and HIV. And the third objective is to prevent sexual violence and manage its consequences.
Sexual and reproductive health is a human right, and it demands attention, not only during the emergency but also prior. What we have been doing in our region is actually that in Eastern Europe and Central Asia with IPPF European Network is that we have been working with the countries in order to establish working groups inside of the countries where they can really focus on the importance of preparedness. We have developed a MISP readiness assessment tool, which is actually a tool that looks at how ready is your country or your region ready to implement the minimum initial service package within sexual and reproductive health. The current capacities and resources of the countries or of a region, what needs to be stepped up, what can be used during an emergency or not. Preparedness really needs to be integrated in the organizations and government's mandates. There is a need to step up funding, to have a budget that is available for the preparedness phase. Investment in preparedness really mitigates the impact of future crises. Currently, very little funding are available for preparedness phases, and the funding only arrives when there is a crisis. But the problem is that when there is a crisis, many other things that are higher are considered as more important, like shelter, food, water and sanitation, for example.
The gap between the needs and the actual funds is growing every day as the crises are becoming more.
In 2014, for example, the United Nations needed a record 19.5 billion to respond to crises around the world. In other words, only 60% of the needs were in fact covered.
We, the Netherlands, is a very strong supporter of giving unearmarked multi-year funding to UN, humanitarian organizations, UN-led pooled funds, Red Cross and NGO partners. In return, the Netherlands expects from partners active collaboration, effective and efficient delivery, and compliance with humanitarian principles and standards.
But where does that money end up? And what are the consequences, for example, of the fact that money for refugee camps to the UN has been reduced by, I think, 2/3 or 3/4 or something? What impact did that have on this agenda?
The problem, I would like to say here, is not a lack of policy. The problem is a lack of implementation and compliance with these policies. This is the result of the fact that an increasing number of state and non-state actors do not respect international humanitarian law, use starvation as a method of war, and do not allow humanitarian access. If you look at the results and the reports on UN-led humanitarian responses, actually the compliance level with regard to all these policies on gender, etc., is going down instead of up. This is a disgrace.
And I also saw this morning in the newspaper that the Dutch presidency had a wonderful new idea, namely nobody will be accepted anymore as a refugee coming to Europe. They will all be coming from Turkey and Greece. They will all be sent back, all, and then about 150,000 of them can be brought to Europe through legal avenues. That means that you send people back to a situation where they are at risk, where they're at a disadvantage. Because when you consider, for example, like the Dutch government apparently does, Turkey a safe country, or Lebanon or Jordan, does that mean it's also safe for women?
The people who live in our place are newly arrived asylum seekers, are also people who have been in multiple procedures, so who have been living in Belgium for many years. 2 families who are living in our center have been living in the center for more than 5 years and who are in Belgium for more than 9 years. And then we also have a large group of unaccompanied minors, boys and girls. So now we have like 10 girls under 14. The youngest one is 10 years old. She lost her parents on the sea, and she's there alone, and she has no one. One of the major issues here is, of course, privacy. There is no privacy at all. For the sexual health of all these people who live here, a very, very big problem. The sexual health of these adolescent boys, who very often come from a context where there is no sexuality, or at least not visible, and it's never talked about. We also provide free and easily available condoms. There are condoms in the waiting room, on my desk, at the reception desk, with the social care workers. There are condoms everywhere. And almost none of these girls are using anything for family planning. Many of the women, but also the men in these centers have experienced traumatic experiences in the country of origin, but also during the journey, and also sometimes in the country of arrival. We try to put extra attention to give extra attention to trauma, but also to family violence, which rises, of course. You can imagine when you're under such a lot of stress. Many women who have been the victim of female genital mutilation, and for this we work in collaboration with Women Do and GAMS, which are 2 organizations, Belgian organizations, who work specifically for refugee women who have been the victim of mutilation. We have to train healthcare providers, not only in the centers but everywhere, in Belgium then, but also internationally, in detecting and dealing with SRH issues. We have to work on long-term relationship with healthcare providers, work on the rights to healthcare for refugees, which even in Belgium is not always the case. There's a big difference, there's a huge gap between theory and reality. We say there is a right to healthcare for example, undocumented migrants, but there's not. It's not seen as urgent, it's seen as luxury.
Any Dutch or Belgian or other European citizen would have to live in these conditions for even 2 days, they would go.